The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone, and thanks for joining for another edition of Ultrasound Case Conference with EchoNose. My name is Dr. Adaira Landry, and I'm an ultrasound faculty member at the Brigham and Women's Hospital in Boston. And I am joined by the one and only Dr. Trent She, who is out in rural Connecticut doing ultrasound and collecting some amazing images for all of us to review. The purpose of this webinar is for you to really see what it's like for ultrasound faculty members to QA, so to perform quality assurance for the ultrasound cases that we gather on real patients in our real clinical practice. So we have asked Dr. She, as he's working in the emergency room, to scan patients as he usually would, but also bring us these interesting and bread and butter cases for us to review. So we'll be spending a couple minutes on each case. We have 3 cases today that are sort of themed around the idea of ultrasound really dictating how much further care we provide for our patients in the emergency room. So Dr. She, thanks again for coming along tonight.
Thanks for having me, Adaira. Always a pleasure. It is 90 degrees out in rural Connecticut right now, so I'm happy I'm indoors. Happy to be here.
It's super humid in Boston, which I appreciate. I love it. I love it. So why don't you tell us a little bit about case number 1? It's a really interesting case.
Alrighty, so let's get started. So I got case 1 going on here. So our first case here is this is a patient that we get called for as a resus sick patient who presents in cardiac arrest. The story that we got was that this patient was found down at home. The presenting rhythm was PEA, or pulse electrical activity, and patient has been down for about 30 minutes, has had about 6 EPIs, 6 rounds of CPR before they got here, and this was in the middle of the whole, this was basically during our coronavirus peak at our hospital, and we noticed that the patient was elderly, but otherwise didn't have too much information on the patient. So as we started to get our resuscitation going, the biggest question in everybody's mind is how fruitful will this resuscitation be? Will it be futile? And so I started with a bedside ultrasound, and this is the parasternal long view that we obtained here on our bedside ultrasounds. And the first question I'm thinking about is like, what am I looking at here, and how much further can I go with my resuscitation?
Yeah, and I mean, for me at least, looking at this, I almost feel like I am seeing some movement. I mean, usually for me, when I'm doing a cardiac ultrasound, I'm looking for, and especially in a cardiac arrest patient, I'm looking for an effusion because maybe this patient needs a pericardocentesis at the bedside, or a large RV because potentially this is a PE and I need thrombolytics, or some significant wall motion abnormality. Is that sort of like the differential you had at this time?
Yeah, absolutely. So I think ultrasound in cardiac arrest is super important, and the biggest things we're looking for are reversible causes, and that's on my differential too, looking for RV dilation, looking for how the LV function is. Especially, I'm definitely looking for a pericardial effusion, seeing if there's signs of tamponade. But with this case in particular, we're 30 minutes in. The first thing I'm thinking of is, am I going to continue with the resuscitation based on what I see?
Yeah, I mean, it's so tricky. And, there have been some studies that have come out that, show that if you do still have the presence of cardiac activity, then that's obviously a better predictor for survival, and there's various studies looking at survival to 24 hours, survival to discharge, survival with good neurologic outcome. I think probably the more reassuring thing that we're looking for in these cases is probably more so cardiac standstill, because I think that is easier for us to stop, like the absence of any movement. I think it gets really tricky when you still see some cardiac activity, which is very poorly defined when you're looking at like ultrasound literature. Like how, I don't know how you are defining cardiac activity in this, like Do you when you're watching this ultrasound clip, are you thinking that this is coordinated, or how are you defining whether or not this is good or not?
That's a great question, and I think when I look at this ultrasound, I definitely see that there is some coordinated activity. I would argue that the activity is pretty agonal and it's not conducive to sustaining life. And this is the most difficult decision that I think I have to make as an emergency physician, when to stop and terminate resuscitative efforts. So I'll say that based on this ultrasound here, looking at the LV function, looking at the decreased activity that we see there, and the large time spent resuscitating this patient, we actually terminated the resuscitative efforts shortly after this ultrasound, and the patient didn't have a pulse, and basically in 30 plus minutes, we never got ROSC. So we were presuming that, well, even if we did get ROSC, our patient likely would not have a neurologic favorable outcome. So
yeah. I think most people would agree with that, like given the entire clinical context. I know there was this paper that came out in 2008 by Dr. Blavis, where they were looking at actually, because right now you're doing TTE. And so this study looked at how TEE actually augments or changes our decision-making when it comes to cardiac arrest. And they found that, doing a TEE, they were actually finding a little bit more of this fine VFib, VTAC that they were missing when they were doing the TTE. And so some of those patients potentially would survive if you were to give them electricity and defibrillate them.
Yeah, that's a fantastic point. I think the prognosis for VFib or pulse VTAC is much better. And I think that looking at this ultrasound, I don't see VFib. It looks again like coordinated activity that is not producing a pulse. So I don't know. I think it's difficult. I don't know what your thoughts are when you look at this ultrasound. In this case, elderly woman found down, 30 plus minutes of downtime, multiple rounds of CPR. I don't know if you would terminate it. Would you continue? I think it's difficult, and all of us have different answers.
Yeah, but I think most people would probably, I would be surprised if this patient would have survived either way. So even if someone were to do 1 or 2 more rounds, this person got multiple rounds of epi. So, what we're seeing could just be that little burst from the epi. And then, if you're not giving them epi, I mean, you could have tried potentially an epi drip. But I feel like overall, this patient probably wasn't going to survive.
Yeah, that's what our thinking was too.
Yeah. One thing though, she does have a lot of, hypertrophy, concentric hypertrophy. So that sort of puts, a possible cause of stroke or MI on the top of the differential. So potentially, if it was something that came in like earlier, you could have considered potentially this being an MI as a cause of arrest. Cool case. So I like ultrasound here because it allows you to feel comfortable, or just gives you another data point when it comes to terminating resuscitation. And it shows the entire room. I like to turn and show my nurses and PAs and whoever else is in the room and say, look, would you agree that this is not a perfusable squeeze? Or we talk about it if there's another resident in the room, just so everyone's kind of involved in that decision making.
I do the same exact thing. And I think, they say a picture tells 1,000 words, and looking at an ultrasound image during that recess, it really does. Once everyone sees the images, they kind of get a sense of where the resuscitation is going. So I agree. I do the same thing.
Yeah. Make sure you save your images though for these ones.
Yeah.
All right. Let's go to the next case.
All right. Next case. So we got a couple images on this case. So this is one of the famous cases where you gets a patient that was sent in from urgent care to rule out a particular complaint. And for this patient, her chief complaint is sent in from urgent care to rule out a pulmonary embolism. And she's a young female, well appearing, was diagnosed with COVID 10 days ago, had been doing well over the course of the week, been feeling better, but today just felt additionally short of breath, had worsening cough, and had some symptoms with exertion. And so she's here now, and she went to urgent care, and they sent her to the emergency department because they're concerned about a pulmonary embolism. And so I think that for this patient's COVID positive and potentially infectious. I think the biggest question is, do we just proceed directly to doing a CT scan? Because we know that in COVID, we see additional findings such as pulmonary embolism. And she was not hypoxic. We ambulated her. She had a room air sat above 95%. Didn't look unwell, did look somewhat short of breath. And so what we did was we decided to get labs. We got a D dimer and we performed a bedside ultrasound. So we started to do this before we went to the CT scanner. And this is our initial view. This is an apical 4-chamber view. You can't really see the RV free wall that well, but just trying to look for pathologies associated with COVID, PE being one, myocarditis being another one. And so just trying to see if we have any abnormal cardiac function that might change if we're going to keep her in the hospital or perform a CT.
Right. So, I mean, some things about this image that I'm looking at, we're a little bit off axis, so which will affect how we compare the chamber size. And that probably is making us not able to see that free wall a bit. So you can always, rotate your patients a bit, swing your probe out just a bit, and try to get that the septum right there as vertical as you can. But looking at it though, I mean, the RV doesn't look huge, but it's really tricky. I mean, I would say it's potentially nearing 1-to-1. I mean, it does look big, like it's flaring out, but we're not seeing the entire thing. But we know that that's not in itself 100% specific for pulmonary embolism. That could be from COPD and pulmonary hypertension, those sorts of things. It's not like a very, it's not, incredibly large. I'm trying to see if I can see, that annulus from the tricuspid moving up to see if the TAPSE is abnormal, but it looks like it's moving quite nicely. And then one thing I try to look for is McConnell sign, which is, that apical hypokinesis on the right ventricle. I'm not really seeing that. So there are some signs here that are potentially reassuring, more so than others, that would make me feel like, okay, if I don't really believe the story too much is PE, if the dimer ends up coming back negative, the stat looks great, she's not tachycardic, she's not very symptomatic, then potentially I would not do the CAT scan.
Absolutely.
Was that your thinking?
Yeah, absolutely. So I think the first thing is, I totally agree with you. The RV isn't so evident in this view. And so I always tell my residents and my learners, if you feel that you can't see something in one view, try and see things in a different view. So I'm going to move quickly to a parasternal long view, which is less so for RV versus LV comparison. We're here looking more at LV function, seeing the contractility of the left ventricle. And I don't know if it portrays well on the GoToWebinar, but when I look at this, I didn't see a pericardial effusion, and just the same way as on the apical 4-chamber view, the LV contractility looks pretty good. It's just I don't see any signs of myocarditis, since we were so focused on PE because she was referred in from the urgent care center for looking for PE, but another big cause of shortness of breath is myocarditis, and you can see a decreased LV function. You can see a pericardial effusion if it's mild pericarditis. And one other view that we got here is this parasternal short view. This is the LV that we see centered on our screen, and we see that the septum bows out towards the right ventricle here, and that's another factor that we have into play. And I think then we went over to our patient. We had the discussion about, should we pursue a CT scan to rule out PE? And well, what ended up happening was our patient's D dimer ended up being negative. We ambulated her again. Her O2 sat stayed fine, and we talked about performing a CT scan and how it would be radiation, it would be additional time in the emergency department, and less so for the patient, but for us, it's exposing our entire CT room to someone who we know is COVID-19 positive. So we ended up not getting the CT scan, and the patient was discharged and did fine, no further bounce back.
Yeah, and that could actually delay some care for other patients too, because at least for our emergency room, if you're COVID positive and you go to the CT scanner, it's like a huge decontamination process afterwards. So the CT is like efficiently or effectively shut down for like a half an hour or so as they clean the room. If you go back to the parasternal long view, I mean, you're right. We don't usually use that view to compare the RV to the LV, but we do. We generally use that RV to look at the diameter of the aorta outflow tract and the size of the left atrium. So, I mean, they do look about 1-to-1, which is like sort of a cheap way of saying that probably the RV isn't too enlarged compared to the other views. So long as you have a good view in parasternal long, then that's like another sort of way to compare the three chambers. And then going back to your peristernal short, you know, you do see that nice donut for the LV, and you really can't even see the RV. You know, if someone has like a large RV, usually it's sort of coming into the picture, depending on if you're at, I mean, you might not be at the, if you're at the papillaries a bit, maybe you can come up a little bit and get more of that papillary, and then you can see the RV a little bit better, but I'm not really seeing the RVs coming into the view too much. So that's also reassuring.
Yeah,
as well
ultimately,
as the
I
shape.
think, agree. Yeah, I think it's just when I remember when I was doing the scan, it was a technically difficult scan as well. So I think what we ended up doing was we broke up our scans into different parts. In the apical four-chamber view, we tried to visualize the RV as best as possible. In the peristernal long, we visualized the left ventricle, and here we're trying to see if we can find the right ventricle. But as you can see, it's hard. But it's good to see that the septum's going out that way.
Yeah, I like the idea of using each, like one view to, you know, try to evaluate one particular part if you can't really do well in one or two together. So nice idea.
Absolutely.
All right, we got one more case.
All right, so our last case of the evening. So this patient, I really remember this patient because in triage, I see him just essentially keeled over. He's in an immense amount of pain. He's got pretty severe left-sided flank pain, and he tells us that he was diagnosed with a 9-millimeter kidney stone on an outpatient CT scan, and he's here because the pain is just really significantly worsening. He hasn't been able to get in to see his urologist, and he looked super, super uncomfortable. So initially what we did was we got IV access. We knew we needed to get our patient under control pain-wise, and I asked him, I said, okay, do you know where your kidney stone is? Where do you have, where did you get the images? And so he unfortunately doesn't have the images on hand, but he gives me the name to a radiology institute that in the meantime of me ordering him some pain medication, I attempt to pursue getting these images in case our urologist needs them, because the one thing I don't want to do is I don't want to scan this guy again. I don't want to go through and put him through another CT scan. And so I ended up calling the radiology institute. Apparently he had never been there as a patient before. Around this time, we noticed that he has an allergy to NSAIDs, and he said he took some Tylenol beforehand. I asked him, have you had kidney stones before? And he's had a urologist see him before. And I ended up calling the urologist's office, and the urologist office actually is not a functional line. And so we went over and did a bedside ultrasound for this patient, looking at his left kidney. And the odd part about this is we're looking at his left kidney right here. I'm looking for signs of hydronephrosis within that kidney medulla, and I don't see any hydronephrosis at all. And it's just, to me, this is it's crazy because he has a 9-millimeter stone. He's in an absurd amount of pain. I was expecting to see some signs of hydronephrosis, and what ends up happening is we end up confronting the patient and we say, hey, listen, your ultrasound of your kidney looks okay. I can't get into contact with either the radiologist or the urologist that you purportedly have. And the labs come back, he doesn't have a white count, his creatinine is normal. And as I'm going back to him to have a discussion and trying to figure out like what to do in terms of pain management and what to do from the next part, I find that he actually has eloped from his room. So he unfortunately pulled out his own IV and then left the emergency department shortly after. So interesting case, to put it mildly, of trying to figure out what to do, what the best way to approach this patient was.
It's so interesting. I mean, I see iterations of this type of patient on a regular basis where someone comes in, they had some outside imaging, and of course, given our medical system, they don't have access to those images when they come to us. So it's always this question of like, do I scan them again? Or do I trust this verbal report from the patient? You can try calling the source and seeing if you can get images over the phone, just the read, or for them to courier them to your location, depending on where it is. Like there's all sorts of complications when it comes to us not being able to see outside images. For kidney stone, this is very common. I feel like I've seen this case often. And so, yes, there is potentially, it sounds like some theme of potential suspicion about the patient's intentions. But if we put that aside and just think about what's in front of us, to me, the big question is, does this patient have a stone that needs intervention, or is it someone who can go home and follow up with outpatient? And so probably the first thing that we think about is the intervention is like, is this a stone that will pass? And so what's your usual cutoff as far as, he said 9 millimeters. That's not a small stone.
No. I think for me, I think that if it's above 5 millimeters, I usually keep the patient in the emergency department and I see how the patient's doing, if we're able to control their pain. For me, I think the things that I always call urology for is if it's a infected kidney stone, if the patient has signs of fever, white blood cell count elevation, or if the creatinine's abnormal, that's a intervention until proven. That's an infected stone or a stone that needs intervention until proven otherwise. For me, if a stone's above 5 millimeters, I usually keep the patient in the emergency department and I say, hey, like let's treat the pain, let's see how they're doing. 9 millimeters, that's a big stone. That probably needs some kind of intervention. And I think that's to me, I think another flag that popped up in my head was, it's interesting that he had this 9 millimeter kidney stone, but didn't go to see a urologist or wasn't sent in for a urology evaluation, because that's a pretty big stone to allow to pass on its own. So.
Yeah, I mean, so depending on which article you're reading, they say 5 millimeters is the cutoff for passage rate, where it's like 90% or something like that will pass under 5 millimeters. That's like the usual, like, do I call urology or not? I mean, I definitely have had patients with 6 millimeter stones who I have not called urology for, just depending on the entire clinical context. But I agree, thinking about 8 or 9, I'm just starting to think about the entire picture of the patient, the reliability of the patient, and how hard it is to get urology to see them, especially during COVID. That may or may not sway me to an ED consult, versus if we were in regular clinical operating hours, where it might be easy for them to get follow-up in a few days. Because like you said, 9 millimeters, potentially not going to pass on its own, or high likelihood at least. So they would potentially need urology follow-up closely. So yeah, I like the idea of thinking about it as like, there should be some gray area cutoff where it's like 2 millimeters, I feel comfortable with you not having a urology follow-up here, just talking about the stone size.
Yeah, I totally agree. I think the really nice part and the real beauty of point of care ultrasound in the emergency department is you don't forget that you have your patient there in front of you as well. So, I mean, for me, like if a stone's 4 millimeters and I see some hydro confirming that there's a stone, the patient's keeled over in pain and I'm not able to control that. That to me probably gets either an observation or admission stay just for intractable pain, and then plus minus a urology consult in the emergency department. So I think that's also an important thing to consider.
Okay, so then it sounds like we're talking a little bit about who are you discharging. So who are you discharging? Like, let's talk about this. What are the hard signs for admission for you when it comes to kidney stones that you're finding on ultrasound or CT, but now we're talking about ultrasound?
Yeah, that's a good question. I think for me, if the hydronephrosis appears like pretty severe, that definitely gives me a little bit of a pause. For me, I think I look at it clinically and I'm looking at the patient and seeing if the patient's just in a severe amount of pain. That's definitely one reason to keep them. If there's signs that it's an infected kidney stone, such as elevated, again, leukocytosis, elevated creatinine, a fever, that's also definitely something that I'm going to keep the patient for. And I think also one of the other things that I had asked this patient before was, had he had a kidney stone prior, and had he needed operations to clear his kidney stones in the past. So I think that anybody, for me, I'm pretty conservative when it comes to patients that have had kidney stones that have required operative management in the past. For me, those at least merit a phone call to urology to say, hey, listen, I have this patient here who has such and such size stone. They probably are going to pass it on their own, but if they don't, I think that they should either be seen like urgently for follow-up, or potentially I'm going to call you back. So I think it's for me, I think the one thing for me is how the patient is doing, if they're clinically stable and if they're comfortable.
Yeah, I sort of break it up into like 3 categories. Pain is a big one, because a lot of patients come in and that's their usual presenting complaint. So if I'm not able to get their pain under control, I usually start off with an NSAID. They can't take a PO because they have so much nausea. I start with a Toradol or some sort of equivalent to that. and then I might escalate to opiates if Tylenol is also failing. But I try to hold off on opiates as much as I can, but if I have to, then I do it. But if they're requiring IV pain meds, then obviously we're going to admit those patients if they're not able to tolerate POs, which is related to usually pain levels being really high. So pain is like one category for me. The second is renal failure, or I'm just concerned about the structural damage of their kidneys from the stone. So looking at their creatinine, like you said, severe hydro with a large stone, if their creatinine's bumped, generally speaking, we're going to call urology for that. And then the third, which is probably the most, I mean, maybe not the most important, but it's like something we might forget about a little bit more often, and it can have terrible consequences, is an infected stone. So something where a patient comes in and they're having subjective fevers or objective fevers and chills. They have a low-grade temp. Their urine analysis looks dirty, which I want to make sure that people know that just because the UA is clean doesn't mean that they don't have an infected stone. We recently actually had a patient with a clean UA, but they looked so ill appearing. They took them to go decompress the hydro that was present, and it was just frank pus that came out. But the UA, the urine test, was completely normal. Isn't that interesting? So I don't rely too heavily on the urine. I look at the entire clinical picture. But again, it's like pain, renal failure, and infection are those three categories. Probably the most important thing would be, who are you discharging? Like, so what criteria need to be met for you to discharge a patient?
So just as you mentioned, patient has to be able to tolerate PO, because if we're going to send them home with PO medications and they can't tolerate the PO medications, they're going to come back in the ED in about a few hours. As you mentioned, no signs of infected kidney stone. And essentially, I think that the patient has to be agreeable with the plan. So with patients who have kidney stones, my spiel that I always give them is I say, hey, kidney stones are usually, they don't cause any long-term consequences for your kidney, because I've seen so many patients with kidney stone, they pass them and then the kidney's completely fine. But it's all about pain management. And I always ask my patients, honestly, do you feel that you're comfortable enough to go home and try some of these pills to control your pain until you pass the stone? And most of the time, especially in this day and age, patients are okay with that. But I think that if a patient is saying to me, hey, listen, like, I still feel really uncomfortable, I don't think I'm gonna be able to manage this at home, that to me tells me I should probably think about keeping them in the department or in the hospital. And that's because if they're telling me right at discharge they're not able to manage the pain, if I send them home, they are just going to come back. So those are big things for me.
Yeah, I like that. And I like thinking about it as, ultrasound in this case got this patient seen quickly, evaluated quickly. A lot of these patients aren't going to be in the ED for as long because they don't necessarily need the CT. So your patients who you might CT would be the ones who are older, first-time presentation of stones, multiple comorbidities, fevers, chills, severe hydro. Those are patients who you're probably going to err on the side of CT, but many of our patients are well-appearing, young, history of stones, not infected appearing, pain's well controlled, and you can actually diagnose these patients at the bedside with signs or stigmata of kidney stones. So don't forget to take a look at the bladder, because sometimes you can see the stone there as well. So Dr. She, this was great. We got to talk about a lot of cases today that all summarized with the idea that ultrasound was able to actually be the definitive diagnostic test for you that limited further radiation or further care or intervention for your patients. So we love to use ultrasound to wrap things up nicely for our patients. Low cost, low radiation, save some time, save some lives.
And before we go, let's answer the two questions that we see here in chat. So the first question I see is regarding to the last case, the kidney case. Did you happen to get a clip of the left kidney? So I'm just gonna bounce back. So this is a clip of the left kidney. Oh, no. This right here is the spleen. We did get a clip of the right kidney as well. And we did end up getting clips of the bladder. Strangely enough, they were all completely normal. I did not see any signs that there were stones in the UVJ, but this was the representative image of the patient having some left-sided flank pain and just having no hydro in the left. And the other question that I think we can talk about a little bit more, it's a pretty big question. How should cardiac standstill affect your resuscitative efforts when you see that in a PEA arrest? Oh boy. I think for me, I think that if a patient is in complete cardiac standstill and they they've been down for a long time. I think that's enough for me to terminate resuscitative efforts. I think the clip that we have in the first image, where there was cardiac activity, it's a little bit more of a there's a little bit more of a question here. But for me, if it's complete cardiac standstill and they've been down for a long period of time, that usually leads me to terminate resuscitative efforts. So I don't know what you think about that, Adaira.
I would agree. Cardiac standstill is more predictive of a poor outcome. Depending on which paper you read, some can say 80% to 95%. If patients are coming in with persistent cardiac standstill and you've tried, then it's going to be unlikely that they're going to survive that.
Yeah, I think if the patient is cardiac standstill and they're asystole on the monitor and there's no signs of life, if I am seeing that on my ultrasound, I usually just terminate the resuscitation right there. So. There probably are some exceptions, like young patients, like pediatric patients, but for the most part, I would agree with you on that. Okay.
Awesome. Well, thank you so much for joining. We really enjoyed this. We're going to continue this series. And Dr. She, thank you for bringing in these cases that I think are high yield and can really affect everyone's care of their patients. Feel free to reach out to us and follow us on Twitter, and keep a lookout for more of these sessions. And thank you again. Have a good night.
Always a pleasure. Good night, guys.